Hey, Mr. Trevor Carew.
Hello, sir. Good morning.
Good morning. It's so nice to meet you. I'm sorry I'm running late. I just got, people just have a lot of questions sometimes, and that was the case today. Now, tell me about you. It's your back, is that correct?
It's primarily in my legs.
Yeah, and
Yes.
tell me, when does it hurt and how's it affecting your life?
I get the feeling of fatigue in my legs. I think you refer to it as being heavy.
Yeah.
And I feel my symptoms sometimes are very different because most people I hear them complaining about sciatic nerves, electric lightning pain. But for me, it's primarily fatigue in the legs. Going upstairs, walking up slopes, it's becoming more and more difficult. Started about 2019 and it's been getting progressively worse. So it's becoming an issue because I don't feel comfortable going on long walks. I am reluctant to travel because I don't know if I'll be able to go up the stairs. If you're going to go up a hill or a mountain or whatever. So I'm really concerned because of the legs. I had tests done from like neurologists, pain clinics, and they assure me that I do have strength in my legs and so. Except once with the pain clinic, they noticed a bit of weakness in the left foot, just like it's just starting. But otherwise, any examination I have, she doesn't show that it's weakness, but as I walk, it presents itself as fatigue. But I do get the sciatic pain. It's going down the back of the legs, both legs. And it presents itself not as electric or lightning pain, but as tightness. Like it feels or like tight, even though it is painful, but it feels more like, and it makes me feel like I want to waddle. Like when I walk, I kind of like waddle like a duck. And I never described it like that until I heard Adele describe it. She has the feeling of waddling too. And then I thought, okay, I'm correct. So only the two of us waddle.
Can you sing like you walk like her, but can you sing like her?
No, I can't. That's the
I
thing.
can't. I don't think anybody can. Well, what you have is called, doctors have a special name for it, and it's the term is neurogenic claudication, and it's a classic manifestation or symptom of something called spinal stenosis, which is narrowing of the spinal canal. And I know you have that anyway because I've seen your MRI. If it's okay, I want to ask you one clarifying question, and then I'd like to look at your MRI and talk about your options.
Okay.
So the one clarifying question is, are you having any trouble controlling your bladder? Are you urinating more frequently or are not emptying all the way? Or does everything feel between your legs like it's working normally?
Recently, like this week, I've beginning to get sensations of like tingling in the area. In terms of bladder, it seems okay. In terms of bowel, I've been getting some doubts recently, like in the last day or two. But I would like to know, how can I differentiate between constipation or a likely problem? Do I take a
It's
laxative, that type of thing?
A, do take a laxative because you want to be on a regular schedule anyway. But B, bowel almost always comes after bladder. So if your bladder is working well, then that's probably not it. And we don't have to go into it here online, but sexual function is usually the first of those three things: bladder control, bowel control, and sexual function. Sexual function, which in a man is getting an erection and maintaining it, that's usually the first thing that goes. So just so you know, but let me show you your MRI because it really kind of shows us what's going on with you and what we need to do about it. This is a cut that goes through your back, straight down the middle. So this is your back, and let me get a little more signal here. This is your back. Can you see my cursor moving?
Yes, I can see.
If you put your hand behind your back as far as you could, your thumb would be right here. And this goes up toward your head, and this goes down toward your bum. I want you to pay attention to this white area because this white is fluid in your spinal canal. And this is a beautiful spinal canal with the spinal cord and the nerves in it until we get to right there. See how it goes in and it
Yes.
goes, the white area, which is the width of the canal, is just a tiny thread there.
Yes.
And that is a problem. That is the spinal stenosis, the narrowing. What they mean by narrowing is it's narrowed down right here.
Hmm.
I also want to point out one thing to you, and that is, see this little white spot right there?
Yes.
It probably doesn't look like much to you, but it makes me nervous because that is the ligament that connects your L4 level to your L5 level, and your ligament is swollen. And sometimes people get spinal stenosis because they have too much mobility at a level. And that's going to be an important thing in just a second. Also on your MRI, I didn't show you, but I can see your facet joints, and they're quite swollen, especially on the left side. So that is another sign of potentially excessive mobility. Just file that away for a second.
Okay.
Spinal stenosis is a bugger. It only gets worse. It's soon going to become so severe that you'll lose control of your bowel, bladder, and sexual function. You're a vital, health, otherwise healthy, good heart and lungs.
Yes.
I mean, you're otherwise a vital, healthy man. You need to have surgery to open up your spinal canal. There's no other option. Oh, I'm sorry. There is one. It's death. Let's not go there. A recent study showed that you have about a 40% higher chance of death within a year from now if you do not go on and get this taken care of. So you, sir, are a great candidate, and it's a no-brainer for you to have an operation called laminectomy. Lamin is the lamina bone, the bone on the that is the roof of the spinal canal. Here she is right here, and it's your L4 and your
Yes.
L5 that need to be ectomied, which means remove. Like tonsillectomy is remove your tonsils. Laminectomy is remove these guys.
Hmm.
That can be done by a spine surgeon using a minimally invasive approach. There's something called a tubular retractor that many use today. You have to look in your area. And where are you?
Toronto. Toronto. Or
Well, you got a ton of good
yes,
surgeons up
Toronto.
there.
Yes.
Yeah.
Yes.
So you have to either find someone there. The Canadian system's a little backed up right now. It
Yes.
could be that you need to look at coming to the US, but you could also, I would start in Toronto and see what you want: a minimally invasive laminectomy at L45. There's something else that needs to be looked at, and that's this excessive mobility. And the reason is, if you have it, the excessive mobility, then you don't just need a laminectomy, you also need a fusion. And the way that you find out if you have it is by doing flexion and extension x-rays. That's where they have you bend far forward, x-ray, have you bend far back, x-ray, compare the two pictures, and if they're different, if there's a slip, we know they're different that you moved, right?
Yes.
But if there's a slip, then you need to get a fusion along with. Did you have those x-rays by any chance?
I met with a surgeon and I had the x-ray done as I left our appointment. So I haven't seen it. But
Okay.
when he showed me the MRI and he mentioned, I see some mobility
Yeah,
issues. And then he sent me for the x-ray and they did the flexion. I was standing, then I did forward and backward.
perfect. Perfect. I love first of all, I love your surgeon. You've got a is it a man or a woman?
It's a man and he
Well, you got a
seems
good
very
guy
well.
there.
Mm-hmm.
You got a
So
good guy there. So I love that. And you're already in the system. I love that too. So I feel like you're in good shape. Get ready to have surgery.
the surgery that he proposed was a TLIF.
Yeah,
That is the
if
yes.
there's movement, I would agree.
Mhm.
And the TLIF is the exact correct surgery. And thank you for having it at L45. That's the perfect level. They don't have to go from the front. They can do it from the back. It's for most of us today, it's a 1.5 hour operation. You can go home the same day or the next day. It's very easy. It's painful, but it's a good recovery. And to be honest, most people with the severe stenosis like yours, They are so grateful to be rid of the radiating pain that they're better after surgery than they were before, even right after. So this is a no-brainer, and I feel very positive, like you're in good hands, and I like the way the surgeon's approaching it. And yeah, I mean, to me, this is very positive.
In the foraminal area in the MRI, do you see also, I think I may have some issues there too?
Well, you do, but it's going to be dealt with by the surgery. Yeah. So the foramen is the hole that the nerve root comes out of.
Yes.
And when the disc collapses and the bones shift, the foramen is automatically occluded. When they do the TLIF surgery, the I in TLIF is interbody, and that refers to the disc space. They go in there and put in a distractor to raise it up, put in a spacer to hold that height, and that automatically jacks open the foramina, the holes. So you do certainly have foraminal problem. But to be honest, the pain you're describing is not typical of a foraminal issue. So I think you're going to get the solution whether you have the problem or not.
Yes. Could it be, would you recommend that I ask about the epidural injection to be able for accuracy? Could the foraminal, okay, so you said my issue wasn't foraminal, because I was going to ask about L5S1, if it's likely there, but you feel it's right at the L4, L5.
But it wouldn't even matter. It wouldn't even matter. You're so narrow at L4, 5 to continue to walk upright on this earth. That has to be taken care of. If, heaven forbid, the pain, there were pain coming from L5S1, and there's no indication of that. It's like you're walking down the block and you've got one fire hose and you see a house on fire and you think, should I aim it at the other house? No. Yes, it is possible. It is possible there's fire in that other house.
Yes.
But this house is on fire, sir, and we got to take care of the main problem. And then later on, even if you had, let's say you had the epidural and you got complete relief at L5S1, you still have to have the L4-5 surgery. So it makes no difference. It wouldn't change what you do. So I would say no.
Okay. But you did mention something sobering, which is surgery waiting for a year could put me more at risk. So if I plan to do it 6 months out or 7 months, which is what I was thinking, that would be okay?
No. I mean, if your surgeon told you he had an opening next week, you need to do it next week. But if your surgeon said, I can't get you in for 6 months, I would say probably going to be okay. Keep a good eye on that bladder and make sure you're emptying. And what you want to look for is not going as often or not or having to go right away after you previously went, meaning it's not emptying as all the way as it should. But if the surgeon said to me, it's going to be a year, okay, that's getting pretty long. If it was going to be 2 years, I would think about looking at other arrangements. I don't think you have 2 years in this with this degree of stenosis. I don't think that would be safe.
Okay, I see. Is there any likelihood to have paralysis at L4, L5 with, lumbar spinal stenosis? No.
I mean, paralysis is extremely unlikely, on the order of getting in a fatal car accident on the way to the hospital. Having said that, there is a higher likelihood of a spinal fluid leak, and a leak, the surgeon would have to patch it up. And then if he patches it up, it could, in the worst case, cause meningitis. That's very, very, very uncommon, less than 1%, but it's possible. The other, if you wanted to look at, well, what's the worst case scenario? Foot drop. Damage to a nerve root that would cause a foot drop is possible. Very unlikely. I think your surgeon sounds like a prince. I just don't think, but let me tell you, think of it in reverse. Okay, what is the risk of these things if I don't have surgery? It's 100%. Instead of 1%, it's 1, but with 2 zeros. You're going to die from this if you don't get this fixed. So who cares what the one, to me, who cares what the 1% or less risk is when
Yes.
the overwhelming risk here is the not having surgery.
Okay. And he also did mention prior to the surgery, he will do also a CT. So he would have my MRI. He has the X-rays, and he'll do a CT scan. So I guess he has.
God, this guy sounds good.
Yes.
The reason he wants to do that CT is to check to make sure that there's no surprises in the bony structures.
Yes.
And I mean, to me, it's just you build trust in someone based on how they act over time. And everything I'm hearing about your surgeon just sounds so good. So I don't know. I feel like you're in good hands.
Yes, his interest is in like spinal cord injuries. He has his PhD. He's a professor. He has he's a scientist, I think, like yourself.
Mm-hmm.
So he's, he seems to be editor of this spine journal here in this thing. So he seems to has very good mentors when he was doing his PhD, the top doctor. So I feel
you're not going to find anyone better. I mean, this is the guy. And so, yeah, I mean, so by the way, if they tell you it's going to be 6 months or a year or something, say thanks, but I'm here. If you have a cancellation, put me in.
I do have a short window. I can take. Yes, he's a few months out, like maybe 2-3 months.
Do it.
I may be able to get
something.
It. Okay.
Just do it. Yeah. I think this is a no-brainer.
With the disc degeneration, when they open up the area and put the cage in, etc., would that ease back pain? And if you have any like lower back pain, across the bottom?
Very much so. So your facet joints are very swollen on the MRI. You have your neurogenic claudication is so severe that you likely can't be active enough to cause a ton of back pain, but I would be surprised if you didn't have it. And so it will be relieved. Even if it wasn't going to be relieved, you would have to have the surgery anyway. But the fusion surgery that the surgeon is planning will address all of the back pain in that area. The flip side of that is you're buying a risk of accelerated degeneration at an adjacent level, which could cause more back pain in the future, which is a very small risk that if it happens could be dealt with without surgery with radiofrequency ablation. So you've got a backup plan and a backup option, and I would just put it out of my mind.
Don't worry about it. And with fusion at L4, L5, is it true that I may even gain more flexibility than I currently have because my L4, L5 is probably bone on bone?
For sure. You can't move right now or it would squeeze off your spinal. And by the way, don't try to move that much, but it would squeeze off your spinal canal. You are going to, even though you're having a fusion, paradoxically, you're going to get more motion back. Yes. So I think that you can count on that being better.
Yes. So I'm one of the persons you would say my treatment, like the last resort treatment, is really the first resort for me.
There's nothing else. There's nothing else. Injections are of no value for this because the hole's too narrow. There's no exercising your way out of this. You need a surgery. There's only one surgery. If you have the abnormal motion, that's an option, and that's the fusion. And I'm very suspicious based on everything that you do have that. So when you consider the system you're in, it makes sense given the quality of your physician and all the stars lining up. Just get it fixed and get on with it.
Yes. The instability or the movement that you see, would that make me feel after surgery a bit more stable? Because sometimes I feel
100%.
Yes.
Oh yeah. Oh yeah.
Is that spondylolisthesis that I have, the movement that you see, or is that instability is different?
Instability is slightly different. Spondylolisthesis is when the bones shift and it's glacially slow so that they're locked in the shifted position. Instability means they're in the normal position at rest. Like, remember, when you had that MRI, you're laying on the MRI table. So even if they moved like that when you're up, they would be back when you're down. So we don't know. They didn't have you move in the MRI. They can't. In fact, they told you over and over not to move, right?
Right.
So yeah, spondylolisthesis is the shift in the vertebrae, which is chronic over time. Instability is movement.
And is that because I lost the disc, most of the disc space, and that's why I
The
got that?
spondylolisthesis actually comes from a failure of the joint to hold it. The disc didn't help, but the disc is the shock absorber. The
Yes.
facet joint is the stability, and the instability is actually due to the loss of the facet joint. Now, the loss of the facet joint is probably due to the degeneration of the disc.
Yes.
So you lost your shock absorber,
Mhm.
then your joint absorbed too much, it went out, and now you've got instability.
Okay. Okay. Look like I've got most of them answered. I looked at your one of your videos, and you did say we must always check off 4 items. What's wrong with me? I need to know that. I checked that. Make sure you had the right imaging and reports.
You did when you had that X-ray as well as the MRI.
Yes. Doctor recommends the usual procedure. Sounds like
Yes.
it's on track. And then your doctor specializes in the recommended procedure.
For sure.
From everything I can see he's been doing. I know he does a lot of cervical. He does a lot more complex surgery, and he comes well recommended by my family doctor, who has patients that he has treated. So I'm working on from that recommendation.
Yeah, for sure.
Okay.
No, you're check. You're there.
Okay.
There's only one thing left, and that's to get fixed.
Okay.
There's 2 things left. Get fixed, enjoy your life.
Yes, I don't know what the recovery would be like. I know it's very personal. I don't know if it'll be weeks or months.
80% recovered in 3 weeks.
What does that mean? Would I be able to go and dance or walk?
No, don't schedule any dances until 6 weeks. You should be walking the day of surgery. You should be walking for exercise the day after. I would try to walk a mile within 3 weeks. And just go out the first day, see how far you can walk comfortably, double it. Usually a good rule of thumb is 10 minutes walk per day per week. So the first week, 10 minutes in a row, not all day, but in a row, 10 minutes. The second week, about a 20-minute walk. The third week, a 30-minute walk is about a mile.
Mm-hmm. And I understand it can take up to a year before my nerves decompress. So I could expect maybe even more sciatic pain after surgery, but in due course, it would reduce.
Very common to have pain afterwards from the manipulation of the nerves during the surgery. That is not a flag of a problem. Mm-hmm. It could be, but more often you can have that and it's gone within a few weeks and nothing to worry about.
Okay. All right. Let's see. I think I covered all of my questions, sir.
Well, I am so happy to meet you today, and this is a no-brainer. I wish you the best. Please let me know how it goes. Yes, contact me afterwards. I'd love to hear from you, and we'll follow up if that's okay.
Okay, Dr. Lehman. Thank you so much.
Yes, you have a great day.
You too. Thanks.
Bye now.
Bye now.
All right. Mr. Carew is on his way to